Yes, ma'am, we are live now.
So hello and
Vipul
good
sir, we
evening.
are live now.
Yes. Hello and good evening. I am Dr. Vipul Chavda. Welcome you all for masterclass by expert on smart weight loss and super nutrition. We at Aero, we are doing multiple webinars for the awareness and education of healthcare professional for obesity awareness and management. This is a masterclass for weight loss along with super nutrition. For this wonderful symposium, we have program coordinator Dr. Dhruvi Hasnani and Dr. Rikin Shah, who are a national EC member, Dr. Dhruvi, and treasurer for Gujarat chapter, Dr. Rikin Shah. We have as a chairperson, Dr. Dietitian Smita Ben Shah, who is a senior dietitian from Ahmedabad and closely associated with our Diacare family, and Dr. Dietitian Shruti Bhardwaj, who is a chief nutritionist from the city of Ahmedabad from Zydus Hospital. I would like to invite you both on this wonderful webinar, and I request Smita Ben and Stuti ji to invite the masterclass expert from the city of Ahmedabad. Over to you.
Yes, sir. Thank you. Smita ma'am, you can please.
Yeah, okay. Good evening, everyone. And this is a very good topic, smart weight loss and the super nutrition. So for that, I would like to invite our first speaker, Dr. Bansi Sabu, that the program that is a curtain raisers for the sarcopenic and the obesity. And Dr. Bansi Sabu, that we know that is no need to give much more introduction for Dr. Bansi Sabu. So I would like to invite Dr. Bansi Sabu for giving the talk regarding the sarcopenia and obesity and the global perspectives on the obesity care. Revelation by Dr. Bhattacharya, ADA 2026. Yes.
Bansi sir always says that he never received proper invitation and introduction because everybody knows him. So he is presently chair at IDF Southeast Asia, and he is also past president of Aero, and he is also editor-in-chief for the Journal of Aero. So with that, I would like to invite to talk about sarcopenia and obesity. The same talk he has delivered at AOSO Symposium at Istanbul. Over to Bansi sir.
So thank you, Vipul, for first of all coordinating this wonderful webinar. It is our first webinar of Aero Gujarat chapter, and we have privilege of our past president, immediate past president, Dr. Mahendra Narwaria. To tell about Aero and Mahendra Narwaria, both is very important on this webinar, on this particular website today where we are here. That one is that Aero obesity chapter, Gujarat chapter was started by Dr. Mahendra. That was number one. At present, we don't have many members from Gujarat. So my second request is all those who are interested in metabolic medicine, please become part of Aero National Chapter. You become the member of that. And third, which is very important, that today we all are talking about weight management. Thinking of writing each and everyone who is coming to our clinic for GLP based therapy. We want to write them for protecting from their heart problem. We are also giving them GLP-1 for good diabetes control, but at the same time, it is the molecule which have a significant weight loss problem. And we are forgetting that it increases the risk for sarcopenia. And when there is very, closely monitoring all his patients for sarcopenia, he's also, making me every day that, you go and come to gym every day to take care of your muscle mass. So this is very important topic that overall Indian type 2 diabetic persons are having less muscle mass. And at the same time, if they are put on a molecules like GLP-1, they further decrease in their weight, but simultaneously they also lose muscle mass too. And then there is a condition called sarcopenic obesity. It means they look lean and thin, but still they are obese. So what I had given talk in ESO, which is European Association of Study of Obesity, ECO Congress. The Congress name was European Congress of Obesity, one of the largest meeting of obesity with more than 4,000 delegates coming from all over the world, where we talked about sarcopenic obesity. So what I am sharing my slides, which I will not take more than 5 slides I will show, and then within 10 minutes we would like to close. So is it okay? Can you see my slides?
Yes.
Yes, sir.
There are many, but this is what is sarcopenia and what is sarcopenic obesity. And it's very important in our clinical practice. And how do we manage? It is always diet and exercise, which is most important. The concept of this, that a person with sarcopenia and obesity, particularly sarcopenic obesity, their expectation of life is always decreased. In India, we not only have the people with obesity, but we also have higher incidence of sarcopenia because of our lean, thin fat Indian, that is what phenotypically which we have. If you go and see all our patients and doing their body composition analysis, this is in across Asia. You will find a lot of people where their muscle mass is also very low. Even their fat mass may be normal or maybe fat percentage is very high. But typically in a person with sarcopenic obesity or even with their BMI maybe 23 or even 22, you will find the fat percentage of these people are very high. Here I am not showing you that YY paradox with Professor Yagnik with a 22.1 BMI, which is absolutely normal as per Indian cutoff. Still, his fat percentage in his body was 34%, while a Professor Yudkin from UK had a similar BMI, but his fat percentage was 9.1. And that's what the difference is. Even he is also absolutely lean, thin, even fit, you may consider, but on body composition or DEXA scan, his fat percentage is very high. We are doing a regularly now body composition analysis. We have put our both the clubs, Rajpath and Karnauti club, and we are finding those people who are coming there for regularly for exercise, but for walking or doing gym, still their fat percentage is more than 25%. And recently, the Asian cutoff we changed. Ideally, male should not have more than 15% fat, not have more than 20% fat in their body. But in Indian or Asian, we have kept it 20% for male and 25% for female. But we normally get more than 25%, even in male, the fat percentage, which is very, very common. As I am a practicing diabetologist, most of my patients who come to me with a fat percentage of more than 25. Now, how you diagnose these sarcopenia? So one is low muscle strength. And I think this is one very important investigation which we can do for each and every person who is coming to our clinic, which is like a simple hand grip strength test. And this is the result last year in our Diabicon, when we changed our Diacon name to Diabicon. Each and every delegate, we had given one device to check the hand grip, and you can check the muscle strength of a person. So that's very important thing which we have done last year. The definition we have changed also for India, I mean the sarcopenic obesity, because there is an Asian consensus which we have created. This is one Asian working group of sarcopenia, which was in 2019. Then I was part of 2021, one of the group where I was is a South Asian working action group on sarcopenia. We have, this is the muscle strength investigation which we get. This is one more important investigation, which is a very clinical examination that you can know a person is sitting on this without using his hand. If he can stand, it's a very simple test with a muscle function, which you can get information about the muscle strength. Some short physical performance battery, which is again not done most of the time in our clinic. So other than hand grip, the balance test can be done. Chair standing test, which is can be done. 4-minute get speed can be checked, or even time get up and get go. These are the some of the investigation, which is a very simple test which can be done in any metabolic clinic, in any place, which is very easy. Hello. एक मीटिंग में हो गई 5-10 मिनट. Muscle mass, which we can also get from the DEXA scan too. These are the diagnostic cutoff points. I'm not going into the details. The same hand grip strength, gait speed, and this investigation which you can do easily in your clinic. This is strength, assistance in walking, rise from a chair, climb stairs, and force. These are the some of the points. You can take the photo. If you can easily screen for someone for sarcopenia. Today we will be discussing not more about the sarcopenic obesity. Rather, today we are going to discuss more about that how we can treat. The best way to treat is exercise. Now, exercising starting at the age of 50 or 60 may not increase your muscle mass. So one should do exercise in young age, even when he is adolescent or even in childhood. But even at any age, someone starts, it is going to help. So it does not mean that if I have not started up to the age of 50, I should not go next day, or someone even at the age of 70 also we should. But aging definitely increases risk of sarcopenia. At the same time, to gain muscle mass back after the age of 40 or 50 is really very high. That means you have to do more physical activity, more muscle strengthening exercise, and at the same time, our diet should increase protein intake, what we are not taking in our regular day-to-day life. So this protein intake, increase in protein intake and doing muscle strengthening exercise, two major public health initiative which we should start under Aero at a national level, at a Gujarat level, at a regional city level, which will really help our people to decrease sarcopenia, decrease fat percentage, then body, increase their lean muscle mass, and overall good quality of life and strength they are going to have. So this is very, very important. This one, there are a lot of paper if you just see about the sarcopenic obesity or sarcopenia in patients. But now we are going to see more and more sarcopenia because of GLP-1 analog. Today, the Acmedix, who is going to support this webinar, they have a high protein replacement formula, which is to be used along with people who are on GLP-1 analog to help the people to have increase in their protein intake. So this is very simple. So the exercise, most important thing, hypocaloric, I mean the diet which contains more protein, which is now this year it is recommended that 1.2 gram per kg. Even it is difficult to take 1.8. Vitamin D and other therapy also to be included in the persons who are taking GLP-1 on regular basis. The exercise have very, very high highly recommended and very important part of therapy that we should not forget. So exercise is the most important thing, and the diet, which we will be talking more in coming, I think, lectures will the diet also. The osteoporosis and sarcopenia is also seen in persons who are androgen less on their sex hormone, particularly in male persons with a testosterone which gets low over the age of 40, 50, 60. So as they age, the testosterone also very important. In female also it increases with post-menopause. So these are some of very important points which we should consider while treating the patient with obesity. We should always see for their muscle mass. We make sure that we do BCA and some muscle strength exercise. If we can afford to have in our clinics physiotherapists or exercise specialists, then we can teach them what are the exercise which they can do at home if they don't want to go in gym, and to increase their muscle mass. And then every time regularly when they come to our clinic, we should follow up them with their muscle mass, how much they decrease in that. We should not follow only BMI or only fat percentage. We should also follow that how much muscle mass they can. With this, I thank once again Vipul for the opportunity, and thank you everyone who are part of this.
Thank you very much. Very informative talk regarding the sarcopenia and obesity, and recommended high quality of protein and engaging in the regular physical exercise and muscle training. And protein intake, we Indians have the very low protein intake. So protein intake should be more, you should increase and distributed protein evenly entire the day, and your body can synthesize about 30 grams protein at a time about for a muscles repair. So divide the protein throughout the day, not only in the dinner and the lunch, also good amount of protein in the breakfast. And while the increasing as the use of the GLP analog and the bariatric surgery for obesity, managing weight loss is not longer our goal, but our goal is must focus on the quality of the weight loss as well as to preserving the muscles mass and prevent the sarcopenia. That is the most important. So our goal, weight loss goal, is to preserve the muscles mass.
So wonderful talk, Bansi sir, as usual. And with that, let's start discussing about the super nutrition and how we can fight this sarcopenia in the era when we are treating obesity with a pharmacotherapy, and this pharmacotherapy has a capacity to reduce not only fat mass but also muscle mass. So to start with, we have experts. First of all, Dr. Sanjeev Phatak sir, who is a renowned diabetologist from Ahmedabad, Gujarat, India. Uh, Globally, we know him, and he's a past chair for RSSDI Gujarat chapter. We also acknowledge the presence of Dr. Purvi Chawla, ma'am, who is a Secretary General for Aero India. And I would like and request, ma'am, if she is open her camera and give few words for this first webinar of Gujarat chapter. It's a very honor moment for all of us. Purvi ma'am, are you there?
I am very much here. How can I miss a talk by Dr. Banshi
Yeah.
sir and this vibrant Gujarat team of RO? I think it's an excellent program that you have organized on a very relevant topic. And I'm taking my notes from everything that Dr. Banshi sir has also said. So, congratulations to the Gujarat chapter of RO. Uh, well done, and please keep it up. This should motivate other chapters as well to take up more activities. Thank you. Thank you so much, Vipul.
Thank Thank you, ma'am. I would also acknowledge the presence of Dr. Parag Shah, sir, senior endocrinologist from the city of Ahmedabad. And I request sir to again start his camera so that we can start panel discussion. And I would request Dr. Rikin Shah, if he's there, to call Dr. Mahendra sir. I think he has and also Dr. Navneet Shah sir to join. He requested he will join after 9:20. So just a quick reminder to him. Let's start with Sanjeev sir. Sir, in this era when we are treating obesity and we are already sarcopenic, and with the pharmacotherapy that treats obesity, induce some kind of sarcopenia. So to preserve muscle mass for long term, which is more important, exercise adherence or nutritional adherence?
Well, it's a great
Sanjeev sir.
question. Yes, thank you, Dr. Vipul. Thank you, Aro. Thank you, Dr. Banshi, and the whole team of Aro. Thank you, Dr. Rikin. Well, I think we should not choose between the two. Both are important. As far as weight loss is concerned, if you want to achieve weight loss, obviously dietary and calorie restriction will be much
अच्छा
more
ठीक है
helpful.
done.
Only with exercise, it is very difficult to lose weight because, for an example, if someone is doing 2 hours of jogging per day and then eating two samosas, all the calories he burnt will be wasted. So, for losing weight, diet plays more important role. But losing weight should not be the only goal, as Dr. Smita Ben told, that preserving the muscle mass is very important. So, to preserve the muscle mass, exercise, especially the resistance training exercise, plays a very important role. So, to put it together, it has to be combination of reducing the caloric intake from the diet as well as increasing the amount of exercise that a person can do, especially the resistance training. So both have a role to play, one for weight loss, and second for preserving the muscles, and then maintaining the lost weight.
Yeah, perfectly said, sir. The both are very important and both goes hand in hand. So my question is to Parag sir. Parag sir, in this GLP era, how we are giving enough attention to preservation of muscle? Because in our population, when we ask as a diabetologist or endocrinologist to our patient that what is their exercise regimen or schedule, more than 60% of the patient are saying that they don't do exercise, they don't have enough time. So at the time of starting incretin based therapy for weight loss, how as a clinician we can give enough adherence, advice or emphasis on muscle preservation? Parag sir. I think Parag sir is not there. Rikin, are you there?
Yes, Vipul bhai.
Yeah, so would you like to answer that how we can emphasize more on muscle preservation by exercise in our patient who are on incretin?
I think exercise, particular resistance exercise, is much more important. So resistance exercise is must, and we are advising all patients from the first day of.
You are on mute, Rikin. Please unmute.
So resistance exercise should be the part of the regimen when we are starting from the day one of the GLP-1 therapy, along with at least 1 gram per kg protein. That is somewhat difficult in current our vegetarian diet. So supplementation is also required along with resistance training, because many times along with GLP-1 therapy, patients' appetite is so much reduced, they are not able to take so-called 20 or 30 gram on each meal protein from diet. Because even after one chapati and some sabji, their stomach is completely filled. They are not even able to take supplement also. So obviously it is difficult to take protein. So supplementation and resistance exercise are must when we are starting the GLP-1 therapy from the day one.
Yes. Bansi sir, are you there? Dr. Bansi sir?
Bansi may be in another webinar.
So let me ask you one more question, sir. That we are having more than 20% of weight loss with pharmacotherapy. Now with the use of tirzepatide, and in some of the patients with semaglutide, also we receive 20% of weight loss. So how in this era bariatric surgery is relevant? Is shifting from bariatric to pharmacotherapy, or is there still relevance of bariatric surgery?
Let me know whether Mahendra has joined or not, so that
Mahendra
I
must be
can.
there, Sanjeev bhai. I don't know. He was there. I'm
Okay.
sorry. In between, you called me, Vipul. I just heard your name. There was one patient, so sorry for that. Tell me.
So Bansi,
Sanjeev
this
bhai, you are
question is
saying
direct.
something. Please continue.
So this question is directed to you, that whether the bariatric surgeons would have a job to do or they would be out of business. I don't think they
Rather,
would be
I
out
am
of
thinking
business.
they
Actually,
will be not
they,
out of weight. Rather, it will increase. The one simple reason is that overall awareness for obesity is increasing so much so that now from primary care doctor to consultant, all variety of obesity specialists are now talking about the obesity management. Number one. Second, we all know from the guideline that person with more than 35 BMI with comorbid condition, actually they need bariatric surgery. The third is that even if you have a person whose BMI is between 35 to 40 or more than 40, we also understand the limitation of therapy which we have pharmacotherapy, which will not able to decrease the weight of someone between 10, 20% or 15% or sometimes 25%. What is more important is even for post-bariatric surgery also, we need to continue some patients on GLP-1 also. Because even they lose their weight by 30, 40 kg, this therapy is to be continued for them, or sometimes just to make sure that they don't regain the weight. Now, what is more important is, this is my personal perspective, that in this complete management of obesity and weight management, whether someone is losing weight or not, but we should not forget the importance of nutrition and exercise, which is most important and most difficult part of it. I mean, to give someone injection or give someone a bariatric surgery option is much easier than the job which is done by nutritionist or by our educator or by ourselves, in terms of educating them for high protein intake and in terms of getting them regularly on exercise. And how much I am myself struggling, I understand, in last 5 years to increase my muscle mass, to increase my protein intake and going daily for gym. I may go every day to club for exercise, but still to go in gym itself is difficult. This is my situation, what I'm telling. Yes, Sanjeev, your comment. Sorry.
yeah, absolutely. So the bariatric surgeons definitely will have a role to play, because if the therapy after 1 or 2 years starts failing, especially the GLP or the dual or even the triple, then what will happen? The patient will have a strong affinity for weight loss and they would not be losing it further. And then they would get frustrated and will want weight loss. And these patients ultimately will end up into bariatric surgery, again followed by the incretin therapy. So the incretins have a role to play. The bariatric surgeons also have a great role to play in near future also. Because the
We are
prevalence
looking
of
at more-
obesity itself is increasing. And that is why all the therapies that are directed at obesity are going to flourish.
Yes, perfectly answered by both of you that they both are not a competitor of each other. They both are complementary to each other.
I would like to just add one comment. If
Yeah,
we
Ricky.
see the data, less than 1% of people are already going for bariatric surgery. If we forget the GLP-1 era, if we go for before 3-4 years, then still less than 1% of obesity people are going for bariatric surgery. Rest 99% only want to do it diet and exercise. So because of the GLP-1 awareness, now more and more people are taking these semaglutide and tirzepatide medicines. So these from these many people are not able to reach their goal weight because of the intolerance of medicine. Some people might have contraindication to those medicines, or some people might not respond even to this medicine. So now more people will be referred to bariatric surgeon because now more people are coming to physicians for weight reduction. Before that, 99% of people were not reaching the physicians. They were reaching to some dietitians or some Ayurvedic, some herbal or anything, blah, blah. You know, all the available on the internet and local markets. So more people reaching doctors for weight reduction, it means more people will be referred to bariatric surgeon. Ultimately, as per my opinion, bariatric surgery and surgeon rates are going to be higher in upcoming years.
Yeah, very well point taken, Dr. Rikin. I would like to ask Dr. Bansi sir that after he attended ADA 2026 and had wonderful two talks there and also at AOSO Istanbul Symposium, what is his single important remark or important changes that should immediately influence the obesity practice in India?
So one is that high protein intake, which will definitely improve or change the scenario.
Okay.
But if you see the research which is going on, this year all phase 2 and phase 3 data, whichever GLP-1 or whichever GLP based therapy is been presented in ADA, their primary purpose was that how much muscle mass is increased. Because at present they don't have the cardiovascular outcome. They have not shown any other data. Even most of these molecules were reducing the weight of around 20%, in between plus minus. I'm saying some of them have shown even 15, some of them have shown 25, except that one molecule which was showing, which we all are looking for, a 30% weight reduction, which is a triple agonist. But still, all of them are looking for that how much muscle mass they are losing. But one thing I would like to say here, particularly on this platform, where webinar, multiple people are joining it, the semaglutide have also done one dedicated clinical trial where they try to see that is it really decreasing the muscle mass. And what they found, okay, yes, there may be, you may look on a DEXA or on a BCA that actually muscle mass is decreasing, but it's not, because there is a intramuscular fat which is decreasing, because they had shown it by showing it by increasing muscle strength. But there are couple of comments also against it on this editorial that it may look, because these patients who are put on GLP-1 therapy, who are in a clinical trial, they are definitely given the standard of care which increases their exercise and which has actually increased their muscle strength. How can you say it is only by the fat of the person? So it's okay, but still it had shown that actually there is an increase in muscle strength. So in this ADA or even in any other meeting of diabetes which we are seeing in this year, they all are revolving around GLP-1 and on obesity management. And future molecules which are going to come, they are looking for that how we can preserve muscle mass and how we can increase the weight loss of a person, that is primarily fat loss.
Yeah, so it is extremely important to have preservation of muscle mass with proper nutrition. So we have two nutritionists in the panel. Before going to them, I would like to ask Sanjeev sir that in this era, when you are prescribing intensive pharmacotherapy, how much protein supplementation do you think is necessary per gram of, or per kilogram of body weight?
Well, previously we used to talk about 0.8 gram per kilogram. That would make about, for an 80 kg person, about 60 gram. But these days, when patient is on anti-obesity therapy, at least we should give 1 gram, if not 1.5. The recommendations are 1 to 1.5 gram. To meet 1.5 is practically very difficult for a vegetarian diet. But 1 gram per kilogram. So for a 100 kg person, 100 gram per day, or for an 80 kg person, 80 gram per day is feasible. And as Rikin said, you will need supplements that would give about 20 to 40 grams per day. In addition, person can have at every meal, with breakfast, with lunch, with evening snacks, and with dinner, every meal should contain about 20 grams of protein, which will make 80 grams. To take 30, 40 grams at a time is really very, very difficult. But 20 into 4, that is 80 gram per day, is practically doable, and we have been doing it in many of our patients with help of supplements, with help of some good products that have been available now with Amul also, the Amul high protein yogurt, high protein shake, and then of course the natural pulses and soybeans and nuts and paneer and hunkered and all that. So I think it is possible to give up to 80 grams per day without causing any GI disturbance in most of the patients. Gradually, you have to increase the protein content, because all of a sudden a person taking 30 gram per day, if he starts taking 80 gram, he would have gastric intolerance. But otherwise, if you gradually increase the protein content of the diet, I think that is practically acceptable and doable.
Thank you, sir. We have Dr. Parag sir here, and I would like to ask Parag sir that now we have a synthetic semaglutide available. So prescription is from specialist, super specialist cabin is entering into physician's cabin as well. But nobody is supported with the team that a clinician who is doing specialty practice is having. The team of nutritionist, team of counselor, team of physiotherapist. So I would like to know from Parag sir that he gives some tips to the clinician or physician who are newly prescribing this GLP-1 RA for diabetes management or obesity management, that what bullet points by you are very necessary for the clinician before prescribing this GLP-1 RA to their patients.
Vipul, just a minute before Parag answer, I want to introduce here Parag Shah. He is a living legend who has lost his fat very, very significantly. Those who have seen him before 10 years and now, and without reducing muscle mass and muscle strength. And that's very, very important. I don't know how he manages his protein, but he definitely manages his protein. And you can see him drastic changes. I'm sure Sanjeev Bhai knows him since last 30 years, but I know him also since last 20, 25 years. A drastic change and without losing muscle mass and strength. Now, Parag, your answer. Sorry.
Yeah, fortunately, I lost before incretin-based therapy became.
Yes, definitely.
Otherwise,
so that's the
everybody
reason
would
I
have
told
said.
you. That's
Yeah.
the reason I spoke very clearly.
Yeah.
It was before the era of
Yeah.
So Bansi, I know Parag for last 45 years.
Yeah,
You must be right. Yeah, I know you told me, colleague,
Yes.
but I know also him plus 25, 30 years.
We were
Yeah, I think-
classmates,
Yeah, actually,
batchmates as well as the unit mates.
unit match. Yeah, we were in the same unit.
Parag sir has managed protein and practice both very well good.
Yeah, I think Dr. Vipul, to answer about some bullet points for the physicians who are not frequently using the incretin-based injectable therapy purely because of the economical reasons, and now it is being available at a quite affordable rate. First bullet point for diabetic patient, I think every diabetic patient undergoing incretin-based therapy or GLP-1 therapy, otherwise also they should undergo fundus examination and to rule out significant retinopathy. As we all know that any sudden reduction into the glycemia by any means would deteriorate the proliferative or a pre-proliferative retinopathy. And that is one of the major reasons where patients may lose vision, not the neons, but it is the diabetic retinopathy worsening. Number two, we tell to our patients that this is a disease modifying agent and weight reduction is an additional benefit. We don't focus too much on the weight reduction alone, because then people would have a unrealistic expectations of these wonderful molecules, even though they may have lost 8 or 10% weight, which is medically quite significant disease modifying. They would not be very happy to continue for a long period of time. Number three, minimum 9 months to a year. And we, at the same time, we tell the patients that it is safe enough to continue rest of the life. We all know that ideally it should be continued just like anti-diabetic or a statin or antihypertensive. But many times looking into the patient's mindset, we may notice that patient is not very keen to take rest of his life or her life. Then we have observed last many years, and since we are a part of the clinical research development programs, once patient takes for 6 months or more, most of the patient would say of their own that they want to continue. They don't want to discontinue because they say so much of benefit. And before significant weight reduction occurs, there is a significant improvement in quality of life. We have seen the patients who had lost a 3 to 4% weight in the first follow-up visit, and they say that my osteoarthritic symptoms have started coming down, my breathlessness has started coming down. So their quality of life, of course, the HbA1c, blood pressure, everything starts reducing. So it's very important to tell the patient it's not a short-term treatment. It is studied to be safe, effective, and now we can say that it can modify many of the diseases. It does not harm any organ, but it may help the many patients with say heart failure or hepatic problems or a renal insufficiency to have the reduction in their deteriorating course of the comorbidity. Just like we are talking about the protein intake and the sarcopenia was there prior to GLP-1. Why we are talking just now? Because in the lay media and the lay press and the internet, everybody talks about the muscle loss with the incretin-based therapy. Nobody is talking about the weight loss with the SGLT2 inhibitor and some reduction into the skeletal muscle mass with SGLT2 inhibitors also. So it's a good thing that people have started talking and worrying about their preserving their muscle mass and muscle strength and improve their dietary intake, specifically to take the good amount of the protein. As Dr. Sanjeev has mentioned, 1 to 1.25 gram per kg is the ideal recommendations. But many of the times if the patient is significantly overweight, we can go by at least 1 gram of their nearer to their ideal body weight. So somebody is 100 kg and their ideal body is 70 kg, so at least 70 gram, if not 100 gram. So minimum would be required. And as Sanjeev has mentioned, gradual uptitrate your diet intake of the proteins and gradually start with the resistant exercise. And gradually you can increase your cardiac exercise, because many of the times those who are having a significant obesity because of the obstructive restrictive lung disease or the osteoarthritis or a heart failure or obesity itself, they will not able to do a medically meaningful exercise in terms of 30 minutes of a brisk or a moderately brisk walk, but at least encourage them to start their doing physical activity. And resistance exercise and simple exercise, as Dr. Mansi also has mentioned, can be started right from day one. So these are some of the bullet points for the physicians who are not very comfortable of starting this therapy, because these are the new molecules for them, because now it has become affordable.
Excellent, sir. You have given a very concise and precise guideline for the clinician who are very new to this pharmacotherapy with GLP. Now we have Dr. Mahendra Narvaria, sir, senior bariatric surgeon and immediate past president for National Aero. And we also have Dr. Navneet Shah, sir, senior endocrinologist and presently chair for the Aero chapter of Gujarat. So let me ask Dr. Mahendra, sir. Sir, in your absence, we discussed that bariatric surgery is going to increase. Rather, pharmacotherapy and bariatric surgery will be complementary to each other. But now we have semaglutide, which is promising more than 15% of the weight loss. We have tirzepatide, which is promising more than 20% of the weight loss. And in future, we are having molecule which can reduce up to 30% of weight loss. But please guide us that which strata of patients should directly go for bariatric surgery rather than waiting for this pharmacotherapy to help them.
So Vipul, since last 30 years or 25 years, we were struggling to treat obesity. So now at least patients started thinking about a treatment. So they are going to a doctor, and doctor also has something to offer. Earlier, there was nothing to offer them. So at least people have started taking treatment. That is most important. So even if, pharmacotherapy is always complementing to us bariatric surgery. Otherwise also, less than 1% people are getting bariatric surgery done, even though they are qualified for bariatric surgery. So 99% people are anyway, they are not opting for surgery. So if at least they can opt for something which will help them improve their quality of life, their comorbidities, and they can at least start some treatment. And if they fail at some stage, they can always come back to ask for bariatric surgery. And those who are already having more than say 40 plus BMI or 50 plus BMI, morbidly obese, not able to walk, not able to do any exercise anyway, they don't have any other option other than getting bariatric surgery done. So by I don't know about rest of India, but in my practice, the numbers are not reduced after this GLP-1 or tirzepatide, which was introduced in last almost more than a year now. But people are coming. So we also see a lot of people coming every day asking for these medicines, and we offer them also. So I think by another few years, we'll be having more number of patients who will be coming for bariatric surgery, and many people will be continue taking this because those who can afford it for the rest of life, they can do it. And if they can modify their lifestyle in after some weight loss, I think it is boon for them. They can do the best of for themselves.
Yes, from the physician perspective as well as from the surgical perspective, they both are believing that they are complementary to each other, and whatever suits the patient best, they should go for that. Let me ask Navneet sir that now we are talking more about precision medicine for diabetes, for obesity, for hypertension. But sir, guide us, what will be the future of obesity management? Will it be more genotypic based or will it be more phenotypic based?
Up till now, we have not found out the genes and which are responsible for obesity. But there are always, we'll able to find out someday that some genes are responsible. Except for the syndromic obesity, the rest of the garden variety obesity, it is all epigenetic or, lot of other than non-genetic factors which are responsible. And these are factors which are so subtle that we hardly can find out that whether it is the only sedentary habits or whether it is food or whether it is sleep, many things. But most important thing, which is I think would be important for uh, development of obesity, would be a neurohumoral mechanism which is responsible and primarily responsible for this thing. Initially, when we did not know much about the hormones, leptin, ghrelin, and incretins, we thought that it is the imbalance between the calorie consumption and calorie expenditure. But I think the neurohumoral mechanism, which is the most powerful compulsive mechanism for the obesity. So in future, I think now there are a lot of awareness, and as Mahendra said, everybody. First of all, the major change has occurred because we have a powerful tool to reduce the weight. Like sildenafil came, then the quacks went away from impotency. Like IVF was established, then there were so many non-allopathic people who were guiding about whether you do this and whether you do that and you can become pregnant. So those are things. So if we have some powerful tool for managing obesity, then and then we'll be able to address the issue. Likewise, bariatric surgery, Mahendra said, why initially it was not popular? There were two reasons. One was the learning curve. There were not many efficient surgeons like Narvaria who did surgery. And then the cost of one-time cost also was very important. So I think genetics will come. We do not know what are the exact genes or SNPs available for obesity. But right now, I think it is a neurohumoral mechanism which may or may not be genetic and responsible for the development of obesity.
Thank you, sir. So till now we are just having a scientific discussion, but let me take you this discussion to some interesting level and ask me some question, the answer of which can have interactive debate. And starting with again Sanjeev sir. Sir, we are talking about 10,000 steps daily that will be sufficient to manage obesity. Many people are claiming that you should do that and you will get rid of obesity. So, is it a truth or is it an overrated thing?
Well, 10,000 step is a good motivational tool to motivate someone that you walk for 10,000 steps and you will be able to burn enough amount of calories. On the contrary, I would advise that 7,000 steps plus resistance training exercise this in combination will work better for all the metabolic benefits. All these years, we have been ignoring the muscle, which is the most powerful organ and least commonly discussed in the medical practice. So I think muscle training or the resistance training, strengthening the muscles, is going to be the key winner as far as the management of obesity is concerned. So 7,000 steps plus resistance training should be the way forward rather than just 10,000 steps.
Yeah, thank you, sir. Dr. Parag, sir, protein supplementation are becoming very common. All the pharma companies coming with one or other brand of protein. So is it actually science behind that, or is it a marketing game?
Definitely, I think with the properly authenticated brands from the reputed pharmaceutical companies, we trust that how much is the protein content, how much is the fiber content, and how much is the carbohydrate. Many of the commercially popular protein containing supplements have actually more of the carbohydrate and less of the protein. They have protein, but carbohydrate content is nobody talking about. Everybody said 10 grams per scoop, 15 grams per scoop. But if you read it carefully, there are lots of carbohydrates also. So I think with all the reputed brands marketing the protein supplement specifically because of the awareness in public in general, in a medical fraternity also, and the need after the incretin based therapy, and as Dr. Sanjeev has mentioned, the need of a good muscle health as a one of the cornerstone of your metabolic health. I think it's not just a marketing, there is a science behind it also.
Yeah, but we have to choose it very carefully.
Yes, yes. You have to ask the patient to read the label, and many of those popular online protein supplements, we are not sure of what is written and what is there inside the actually contained.
Exactly.
Any protein powder which patient feels very tasty and easy to take are something which patient should be thinking twice, because like Bonvita is very tasty, right? But if you see the content, it is one of the most unhealthy supplement, so-called protein or a health supplement, which we can think of, for example. So all proteins are not likely to be as tasty as a Bonvita or a popular drinks. So we have to know that whoever is marketing for the lay people, they say that it is 70% protein or 80% protein, but actually how much would be inside, we really are not very sure of. So we recommend patient to take the supplements from the sources which we are confident of what is written and what is provided is practically the same.
Yes, sir. So let us ask our nutritionist over here in a single.
Comment?
Yes, sir,
May I
please.
make a comment, people?
Yeah, of
I
course, sir.
think we need somebody who is very literate and can teach us about the protein, because we do not know what exactly protein is. There is a soya protein, there is a plant protein, there is a whey protein. The proteins are different. Then we do not know about the absorption of those protein, what is we are going to get it, and how much we can take it. There were some protein supplements which contain lead, and they were taken from the market also. So I think we need to assess in detail that what is the right kind of protein for the right kind of patient. So I agree with Parag that we need a lot of insight regarding the protein consumption. Like Bonvita is a predominantly a carbohydrate drink, and it is not a protein drink, but people drink because of some protein content.
And the leucine isolation ratio also.
That is
All
also,
the things, yes.
Exactly.
that is also important.
I think Navneet sir has mentioned that I think we have, Vipul sir, you had mentioned we have so many supplements nowadays in the market, and each one contains different type of protein. Maybe one has soy, one has whey. But important is that all the supplements are not only containing protein, they have micronutrients,
So
they
I
have
will
carbs,
ask
calorie.
I will ask you a very specific question that we are talking about incretin therapy induced sarcopenia or only patient who are having sarcopenic obesity. So what should be a co-prescription with GLP? Is there any specific brand or is there any specific composition that a person or a obese individual who is taking pharmacotherapy, which is incretin based, should take as their co-GLP.
Yes, sir. So you want to ask that, yes, definitely they require supplementation, and there are supplement specifically designed for the patients who are on GLP-1 therapy. So
Exactly.
the in terms of protein content, in terms of calorie content, the amount is less. So definitely we can prescribe them. But again, when we are talking about precise, when we are talking about personalized, but first we need to assess the patient eating habits and their lifestyle. Then only what is fitting into patient eating habits and lifestyle we can suggest them.
Vipul, what is happening nowadays that everybody start writing GLP-1 and tirzepatide, and nobody guide these patients to do exercise and take protein. See, people
Yes,
keep on
sir,
writing.
yes.
I had seen muscle loss significantly, sarcopenia happening them, including myself. I took tirzepatide almost for 2-3 months. I lost 8 kg and I lost 1 kg muscle out of it, which I'm having difficulty in getting back because I do a lot of exercise, I take a lot of protein, but getting that muscle back is really very, very tough. So muscle loss is very easy to lose, but getting muscle back to normal is almost nearly
It's very
impossible.
difficult.
So somebody who is doing good exercise, taking good amount of protein, and we should start giving this medicine in a level which should be sufficient enough to maintain their muscle mass. Once they're losing muscle mass, I think we should reduce the dose, increase their protein intake, exercise intake, and then we can add increase the dose. That's the ideal way, which nobody does it. Actually, physicians don't have time to see all these things, and they keep writing. I think now everybody can prescribe Mounjaro or tirzepatide or GLP-1. In fact, nowadays even patients advise to each other and they take it themselves without even asking us. So I think it is a major pandemic which we are looking at in next few years. We will having sarcopenia as a separate society, and we will be talking about sarcopenia as a disease which everybody will be fighting in future. And I think it's already started in the US, the Sarcopenia Society of the America, which they have a lot of conferences going on that. So in future, we also will have a separate society with Aero having only sarcopenia as a disease.
Yeah, so hot question, sir. Yeah.
Mahendra.
Sir,
Yes,
after
sir.
5 years, what? Yes, no, it's sir.
Yeah, go ahead, Vipul.
No, sir, you tell.
Sir, Sanjeev, sir, yes.
Yeah. Yes, absolutely. So I think sarcopenia specialty may develop of its own out
Yes,
of
sir.
the weight loss therapies, all that we have. Having said that, majority of patients who are doing exercise right from day one and are taking good amount of good quality protein, they are having very little muscle loss. We have patients who have not lost even a single kg of muscle in spite of losing 20 kg of weight. So all the weight that is lost is either from the fat or maybe from the fluids, but no muscle loss. But these are few exceptions. Otherwise, as Mahendra said, even 10 or 20% of the muscle loss may make the patient less energetic, and that's why we should try and prevent the most powerful organ of our body, that is muscles.
So
Otherwise, we'll have sarcopenia all around.
yeah, even I have few patients who has gained muscle after
Yes.
even taking this medicine, but they're taking good care of themselves. They do a lot of exercise, taking good amount of protein, what is prescribed to them, which is next to impossible, particularly in vegetarian diet. I take everything and my protein intake. I take almost every meal I have protein, and still I could lose muscle. So I'm afraid to take Mounjaro again or tirzepatide again just because I don't want to lose my muscle mass.
Yes,
One
sir.
comment on my
Yes, sir,
side,
last
because
point.
self-injection is there. Self-injection is already prevalent, but still many patients are lost to follow-up after this prescription. These patients also comes up after 3 or 4 months with so much muscle loss and even with skin loss, hair loss. So follow-up is also important, and every time visit BCA is important when we are prescribing these GLP injections to evaluate the therapy, all our monitoring therapy.
I think hand dynamometer is another tool which we can use in our clinical practice, which can be used every week. If you're not getting at least BCA, we should do a hand dynamometry to see the muscle sarcopenia effect. So that is a very strong tool which we can use every day actually.
Yes.
Yes.
Correct.
So Mahendra sir, what is the future of bariatric surgery? What are you seeing next 5 years? Will surgery increase or decrease?
I think it will triple.
And sarcopenia will be a iatrogenic complication as per Sanjeev sir.
So I think number of bariatric surgeries will increase now, because now we will see people who cannot tolerate these medicines, who has failure of these medicines, and who cannot afford to take them for the rest of life. So I think, but at the same time, they had seen result of the weight loss because of these medicine, the benefit of this weight loss because of medicine. So they will come forward to have further weight loss.
Exactly. So bariatric surgery will be the maintenance for weight reduction after pharmacotherapy. It will be the different perspective after 5 years.
So after this medicine, I had 3 GI surgeons working with me to do more bariatric surgeries, and one endocrinologist to prescribe only GLP-1s.
Great, sir. So it was a wonderful discussion in last 45 minutes. So let's enter a last grand finale round, which is a rapid fire round. And I would ask one question to each panelist, and I would request to give answer in 1 minute, starting with Parag sir. Parag sir, which is the most underrated nutrient?
I think fibers.
Please guide us for in a 1 minute, sir.
Yeah, I think
How?
fibers are very good for the natural incretin to increase the effectiveness of the incretin based therapy, to improve the gut microbiota for the better, and it gives a good relief of the constipation, which is one of the common side effect of GLP or GIP-1 agonist. So it will give satiety also. So start protein and fiber first before you take your major meals or snacks.
The most underrated nutrient is a fiber, as per Dr. Parag sir. Navneet sir, which is the biggest obesity myth?
I don't know, but if people say that it is all because of the patient's habit or patient's lifestyle which makes them obese, then I don't agree to that. Because many a
खाता पीता
times,
घरना हो એટલે obesity હોય.
many a times the lifestyle is not responsible for obesity, but it is the
Yes.
neurohumoral mechanism plus minus genetics which is responsible for obesity. So I would really have sympathy. Initially, when we didn't know much about that, then we used to hate obese, like alcoholism. Did not like alcoholics, but now we see that you look at the receptor dependence and people become addict to the alcohol, then it is not only their fault. So it is something like that, that if one says that obesity is only because of the lifestyle changes and because of the bad willpower of the person, then that is the biggest myth.
Exactly.
I think it is a history which is responsible, because our genes have seen starvation in past. So the new genes, when they get a lot of calories as an intake, the body want to take it and store it. So I think, and everybody is developing that kind of habit. So when I was a small kid, I was the most obese kid till my 10th standard. Though I could maintain my weight with the lifestyle changes and everything, but a lot of effort is needed to even maintain that.
Exactly. I find Sanjeev sir is always solution oriented. So let me ask sir, which is best exercise for obesity?
Well, the best exercise the patient can do on a long term for next 5 or 10 years, which the patient enjoys rather than forcibly does. Because sustainability beats the intensity. So I would go for an exercise which the patient will enjoy the most.
Exactly.
I think
And
people, the
Mahendra sir,
best exercise is, instead of this, you should do this.
exactly. And Mahendra sir, should
Absolutely.
pharmacotherapy.
But it is the most difficult exercise, Mahendra. Offered an ice cream, to do that exercise is very difficult.
Yes, sir. So Mahendra sir, should pharmacotherapy tried every time before for surgery, or can we go directly straight forward to surgery?
No, pharmacotherapy is not required to start unless until somebody is unfit for surgery. Those are super obese people having compromised heart, lung, and even lot of edema in abdominal wall who are not fit for surgery, who are not ambulatory. We can reduce some weight for some time. Like I had a patient who was on in ICU on ventilator, came out, and then was on home oxygen. So these patients who are waiting for surgery, yes, these pharmacotherapies should be instituted to lose some weight. We make them fit for surgery, and then we can operate them. And in future, after surgery, even if they are those who are not reaching their target, we can always add pharmacotherapy, and those who are gaining weight, we can always add. So it is a concomitant therapy, or just like chemotherapy, we can always add after surgery also.
Yeah. Now we ask Dr. Rikin, who is the youngest doctor in this panel. Rikin, what will be the future of obesity care in India? Will it be a lifelong therapy like hypertension or diabetes, or there will be something that will actually cure obesity and patient can exist the therapy plan?
I think we are happy that we have now power molecules which can even treat obesity. And most people will require long-term therapy. But according to me, in a practical purpose, patients will take this syrup for 1 year. They will reach full weight. After 1, 2, or 3 years, they will again gain 5, 10, or 15% weight reduction. They will again come for this therapy, take 2 or 3 months, and again they will reaching full weight. So it will be on and off mechanism. And many patients can futurely they will self-prescribe this medication after learning all the dosages. So it is going to be on and off for most cases, and a few patients can take with diseases like diabetes or heart disease. These patients are already on multiple medications. These patients are already on insulins. They will continue their CLP-1 medications for long term, not only as a weight, but as a disease modifying agent to reduce the CV risk, to reduce the renal risk, and to reduce all our mortality.
Yeah.
So
Wonderful
that means
answer.
the medicine will go out of control of physician in future. People will keep taking and giving to each other instead of, because there is no hypoglycemia like insulin. If you take high dose or low dose, so there is no as such bigger side effect. So they can always manage their doses. They learn how to take it. Everybody can take it. It's so easy to take. So where is the role of physician in future? Maybe after 2-3 years, somebody is on this medicine. Will they come back to your clinic to get it prescribed again? Or they'll take
Yes,
that.
they will come back because still there
Yes,
many
use
patients are
will
coming back
definitely
I
when they
think
are even able to lose weight.
pharma companies have better future than the doctors, it would mean.
Yes, true.
One quick remark for me, because many a times patients are not losing weight with the same dosage of semaglutide or same dosage of tirzepatide. So when they are not losing weight, they will come to again, okay, doctor, I am not losing weight at the same dose. Then they will have loose skin, when they will have hair loss, or because of this, I think complications, they will come again. Please solve this my problem. Like in diabetes, many patients are not coming regularly. When they get high sugar, when they get some complications, then they come to follow, do a regular follow for some time. Then again they go to non-compliance.
So in Indian population needs somebody to blame upon when anything goes wrong. So I think they will come to doctor because any side effect is there, they need somebody to blame on. So they will not leave doctors. So it was a wonderful discussion to have all of you. It was a first webinar by Aero chapter from Gujarat, and we have all esteemed panelists who gave wonderful answer and guide us all. So before we go to the closing ceremony of this important symposium, I would like to ask one line if you all want to give to the population of Gujarat that one thing they should do to fight against obesity, fight against obesity that causes many metabolic complications. There are 220 complications that are there because of obesity, from diabetes to hypertension to heart issue to kidney issue, including sleep apnea, osteoarthritis, and cancer. So one answer or one suggestion from all of you, starting from Smita Ben.
Very good.
One suggestion to all population of Gujarat.
Yeah, for all Gujarat, for all the population of the Gujarat, first is the control the obesity, go for the lifestyle modification, good amount of the nutritions, and do regular exercise and lifestyle modification. That will help to reduce the diabetes as well as the obesity.
Thank you, Smita Ben. Shruti ji.
Yeah, so I think focus on the sustainable results that one can maintain, as we are discussing that sustainability is more important. So whatever they are doing, try to lifestyle and everything, that what they can sustain is more important.
Consistency is more important than intensity. Perfect. Dr. Parag, sir?
Yes.
In Gujarat, in the diet, the main problem is the high amount of the fat along with the high amount of the carbohydrate.
Yes, sir.
We all are a fat living community in Gujarat. Everything, whether it's a vegetable or a hando or a dokra, we make it unhealthy by putting lots of oil in it. So, as our PM is telling to reduce the fat by 10%, we say at least reduce by 25%. Because 10% is
Excellent.
nothing for the Gujaratis to reduce the fat amount in their body. So, increase protein, decrease the fat, and increase the fibers and the protein in the diet.
Excellent, sir. Dr. Rikin, please unmute
Yes, I
yourself.
think nutrition is the most important part in every GLP-1 therapy. And as Dr. Parak sir said rightly, we require more fat reduction in our diet. And when we take some funny comments, when we prescribe patient that you should take 100 grams daily, they do paneer saute, they add more and more oil, they fried paneer, and after frying paneer, they take it. They are taking so much oil with it. So making a healthy recipes is also important.
Yeah, thank you.
And all
Dr.
our long-term
Mahendra, sir.
sustainability is
Mahendra, sir, your remark, your advice.
So, obesity is a chronic, lifelong disease which needs a serious and lifelong treatment. One should not think of having a shortcut to get it treated. Just like diabetes and hypertension, we should be prepared ourselves to get it treated for the whole life. And lifestyle is the most important part. Then the nutritional modification, and then comes the pharmacotherapy. I think those who are opted for lifestyle modification and nutritional therapy should get opted for pharmacotherapy to help them losing more weight. And those who cannot, yes, definitely, those who are more than say 35, 40 BMI, we can always opt for bariatric surgery.
We are happy to help with surgery. Perfect. Navneet, sir.
I think there are two components from my side. One is that we need to have a great awareness about the sarcopenia, obesity, and adiposity, and we have to train the people that what is the difference between these three things. Like I would say that to manage with GLP or whatever you think, at least you should look at sarcopenia first before starting GLP. Improve their muscle mass, then you put them on GLP-1. And second important thing is that we have been trained to eat from the birth till today. So we should be trained to eat healthy instead of trained to eat. So that is very important. And again, that should be coupled with the necessity and exercise. We don't do any exercise, but we time based eating, because we have been trained. આપણે જન્મ્યા ત્યારથી જ આપણને રડે તો ખાઈએ કે સ્કૂલમાં જઈએ તો ખાઈએ કે કંઈ થયું સેલિબ્રેશન, એટલે આપણને જે ટ્રેનિંગ છે ખાવાની, that should be changed, and we should be trained to eat healthy, and we should the food should be a reward after doing an adequate exercise. That should be the thing.
So, sir, I love one of your slides which you always talk about: eat before eating, eat after eating, eat when you're hungry, eat even if you're not hungry, eat before eating, eat after eating, eat to celebrate love,
Eat
life, success,
anytime.
purpose.
Eat
Absolutely.
anytime. If there is a celebration, birth of the child is the eating, or marriage is the eating,
Yes.
getting a
So,
degree is the eating, even death is the eating.
yes. So I love that talk of yours, which I listened long back.
Yeah.
Thank you.
Sanjeev, sir, final remark to the population of Gujarat, India, conclusion of this webinar.
I think the health education should start from preschool and school, from the school teachers and parents, about the diet, about the importance of physical exercise, about the importance of sleep. Because if you make small changes in large population of Gujarat or our country, it would have a large impact rather than making large changes in a small amount of population. Same thing stands true for diabetes, for hypertension, for any chronic metabolic disease. That small changes in large population would have a greater impact than large changes in people who already are suffering. So, prevention of obesity right from the childhood should be started by the parents and from the school teachers so that we do not see bad future of our next generation.
So I think
Preventing obesity is
parents should be
cheaper
treated
and
first for obesity, then only we can treat the kids. So the problem is when the parents are obese, they can't force their kids to adapt to a better lifestyle. So whenever I operate, I always tell them if somebody is obese in the family, even the kid who will get surgery done will also fail. So it's better that everybody should get treated for the obesity so that they can have a better outcome.
I absolutely agree.
Into the nut.
Our efforts should be community based for all non-communicable disease. We should not focus on the individuals or on the families, but it should be a community. And when we
So
change the community, then the difference would be seen. So if a person from one family comes for diabetes and you do whatever for him, but the larger benefit would only be available when you treat the community.
Excellent, excellent message by all the stalwarts. Preventing obesity is always less costlier than treating obesity and its complication. We are dot on time. We have amazing discussion. Now I would request Dr. Rikin to toss vote of thanks for all of us, for Acmedix and for RX.
But a big round of applause for Dr. Vipul Chawda, who moderated the session in a great, interesting way, interactive way, and for framing all these questions, which are very, very clinically relevant. And
Yes.
to remain silent,
Yes,
in
there is
spite
one
of
more.
knowing on the answers, is extremely difficult. I understand that, Vipul.
We have one more person who is behind, actually behind the camera. I would acknowledge her presence as well.
Oh, yes, Dhruvi. Hello. So, congratulations
Listening
and
to
thank
all
you
the
to you too
people.
for making this possible.
No, thank you so much. Thank you for coming together on an evening and being there till so late. And thank you to everyone for doing a wonderful job.
Yeah, Rikin, please. For vote of thanks.
Yes,
Dhruvi, you
thank you.
should,
First of
Dhruvi, Rikin, 1 minute. Dhruvi, you should thank me more because I'm in jet lag and I'm still feeling drowsy, and even then kept my eyes open.
sir, you are
Absolutely.
chairman, you are chairman of the Aero Gujarat, so you don't have any choice. You have to remain awake.
So,
No,
even during jet lag, sir, you are so alert, sir. Absolutely alert and interactive.
absolutely. It is amazing how you guys pull it off,
Yeah.
starting the morning so early and working till later in the evening, still seeing the patients, doing so much of research, academics, and clinical work. It is amazing how you guys pull it off. An inspiration for all of us.
And I think one last thing which I think everybody forgot is the sleep, which nobody talked about. Sleep is the most important part of our lifestyle modification, which people don't take care of it, they ignore it. So I think those who are sleeping late and getting up late in morning are having more risk of getting
What Dr.
obesity.
Fraternity.
Message
I
was
Next
mentioned
meeting
I
will be
mentioned
7 to
it.
8.
it was
Next
direct.
meeting will be 7 to 8.
So I mentioned about it, Dr. Mahendra.
Oh, sorry. Then I was
Sleep
not.
is important and it should be with the at par with the diurnal rhythm. That is
Yes,
also
true,
very
true.
important. Not the
Yes.
only amount of sleep, but it should coincide with the sunset and sunrise.
Sunset of sunlight. Yes, sir.
Yes. So
Yeah.
night shift people are at more risk of
Mm.
metabolic diseases.
Melatonin is more important in
Yeah, that's true.
But the
Gen Z never
messages
sleeps
so
for
were
you
day
start
so
taking
changes.
melatonin for
supportive.
3 days and you'll be fine. Your jet lag.
I know, but I'm afraid of taking medicines somehow.
Okay. Thank you, sir. Thank you. Thank you,
Okay.
everybody.
Rikin,
Okay.
Thank
Rikin.
you.
Thank
Thank you,
you.
everyone.
Thank you. And good night.
thank you, Dr. Mahendra Narwade, and thank you, Dr. B.M. Makkar sir, for recognizing our Gujarat chapter of RO. Thank you, Dr. Sanjeev Phatak sir, Dr. Bansi Sabu sir, Dr. Parag Shah, Dr. Namit Shah, Smita Ben, Suti Bardwaj for all this wonderful collaboration. All have done wonderfully, highlighted all the aspects of obesity, side effects of GLP-1, co-prescription. And I think concluding message is a nutrition is a compulsory, and we should all patients should be put on high protein prescription, particular if you can provide for GLP. And thank you, Acmedix Pharma, for answering this.
Thank you.
Thank you.
Bye-bye.
Thank you. Good night and Jai Hind.
Jai Hind.
Jai Hind.
Jai Hind.
Jai Hind.
Jai.